This video is on multifocal contact lenses at Precision Technology and Cardinal Contact Lens. Let's talk about how the various multifocal lenses are constructed in our industry, as well as the challenges we face in dealing with the presbyope, but also how we might use multifocal lenses in young kids as well as a myopia controlling device. Now, presbyopia is much more than just a loss of the accommodative system. There are anatomical reasons why we are more challenged when we fit the presbyopic eye. It's more challenging from a contact lens perspective. It's more challenging from an optical perspective. What does that mean exactly? Well, the aging eye has reduced tear production, making it more difficult for contact lenses to be comfortable and perform well. We have a loss of contrast sensitivity, making it difficult or more challenging to see objects exceptionally clearly, especially in changing light conditions. We have reduced transparency of both the lens and the cornea. We deal with the decreasing pupil size, the senile miosis, so less light being able to get into the retina. We have increased lid flaccidity, making it more challenging to center contact lenses. We have the inability to cope with reduced light, so patients are more sensitive to the loss of the reduced lighting conditions, driving at night as an example. We have a reduction in retinal sensitivity, and then our patients have great visual expectations for their various hobbies and their lifestyle. So there are many challenges in dealing with the aging eye. We have numerous different types as an industry of multifocal lenses. We have monovision as an option, not a multifocal, but one of the lenses that we apply with great frequency in the presbyope. Monovision, of course, providing one lens for distance vision, and in the opposite eye, one lens for magnification at near. We have translating multifocals where the upper hemisphere may be devoted for distance, the lower for near. When the patient looks down to read, the lens hits the lower lid. This transition line moves up above the margin of the pupil, and the patient gets well into the near portion down below. Aspheric multifocals dominate the market. So you have multifocality from center to periphery to provide the patient with simultaneous vision or with some minimal amount of translation. Then you also have annular zones where you may have near in the center or distance in the center, and then toward the outside you have your opposing magnification. In soft multifocals, they're almost all simultaneous vision multifocals. So the multifocality is placed within the margins of the pupil ideally, and the patient is able to get the near and distance that they want, or at least that's the idea. And then last is hyperopic ortho-K. We have the ability to steepen up the central cornea and create a multifocal shape on the anterior surface of the cornea, creating some assistance for the presbyope. Now, it's interesting to look at the percentage of patients that wear contact lenses in the younger ages. So under 40 years of age, we're into something like more than 84% of our patients are in soft lenses under 40 years of age. But after 40, there seems to be this very low percentage, even though it doesn't change the number of myopes or hyperopes out there, the number of astigmats. So why is it that so few contact lens wearers are passing that 40-year threshold? Now, presbyopia must factor in. 18% of patients drop out of soft lenses due to the onset of presbyopia and the inability to focus at near. But high percentage dropout due to comfort. Is this due to the aging eye and the drier eye that patients experience as they age? Is it due to the optical reasons, the smaller pupil, the challenges that we face in dealing with the presbyopic eye? So certainly 18% of patients are dropping out due to presbyopia by itself, and that's specific to soft lenses. Now, multifocals represent a relatively small percentage of the contact lens marketplace. 11% of soft lens wearers are wearing multifocal lenses. Slightly higher amount of GP wearers are using multifocal GPs. Is that due to the better optics that GP provide, or do we make better GP lenses? And that's an argument that's worth having. However, it's a small percentage regardless of whether it's a soft multifocal or a GP in the marketplace. Now, Ravi Bakkaraju did this interesting study with this incredible optical device that he created. What it allowed him to do was simulate the kind of quality of vision that a patient would experience through to the retina. So a standard E was presented to this mirror, then through the contact lens and to the camera to give us an understanding of the quality of vision that patients might receive through an actual lens. So not on human eyes, but done to simulate what would be presented to the retina using various powers, using various ads, and using various pupil sizes. Now, if you look at a 3-meter distance and the big E at 3 meters, what would the patient see through a single vision lens, a non-multifocal lens? And here's the big E, looking relatively clear. Now, if we put up the various multifocal lenses and try to have an understanding of the quality of vision or the quality of that E, we see relatively reduced in visual quality when we push that light through the multifocal contact lens. And the same thing at near. Very challenging to get a really clear image to the retina through these lenses. So there are some optical challenges of multifocal lenses. This may be part of the reason why so few patients are wearing multifocal lenses into their presbyopic years. Could it be the optical quality? And this study by Hong looked at the aberrations that one would pick up through a single vision spherical glass lens or a spectacle lens, through a silicone hydrogel soft lens, and through a GP. And what we find is the aberrations were lowest in the GP lens, which is no surprise. We've long known that the optical quality of a GP is generally superior to anything else that we can place the patient behind. And if you want to test this simply, put a soft lens on the lensometer, then put a GP on the lensometer and see which one has sharper mires, which one is giving you a better optical quality. You can also do topography over top of the lenses on eye and look at the reflection of the placido. Which one gives you a sharper placido reflection where the rings are more parallel, which one less? And generally you're going to find the GP is going to be superior in both those tests. Now, in terms of soft multifocal lenses, we have a number of different designs, but there are three principal basic presentations. One would be the aspheric near center multifocal, where you see the hotter colors in the center, colder colors toward the periphery. Near in the center, distance toward the periphery. Then you have your aspheric multifocal with a distance in the center. The colder colors in the center, warmer toward the periphery. Then you have your multi-zone lens, where you may have distance, near, and you have multiple zones as you move away from center. The attempt being in all these lenses to provide simultaneous vision, meaning all the focal distances are provided to the patient, and we are hoping that the patient will be able to pick up the power or vision they need for their visual function. Now, another challenge that we face in all contact lenses is the difference between the optical axis of the eye and the patient's visual axis. In other words, if we were to run a point of light through the center of the cornea to the center of the retina, that line will be slightly different than the patient's line of sight based on the temporally displaced fovea. So that difference in angle can be known as angle lambda or angle kappa, but effectively what we're describing is the difference between the geometric axis of the eye and the visual axis or the patient's line of sight. So what does that mean? If we place a contact lens centered perfectly to the geometric axis of the cornea or of the eye, that center will be different from the patient's line of sight. In other words, the patients are generally looking through the nasal side of the contact lens because the visual axis and the geometric axis are slightly different in angle. Now, if we look at the position of soft lenses, are they actually centered to the cornea, to the pupil, to the visual axis? And in this study at Pacific University, it was found that the vast majority of soft lenses on the right eyes tended to decenter slightly temporal. The vast majority of left eyes tended to decenter slightly nasal. So there is some difference between how lenses center on eye. And what does that mean in relationship to the geometric axis versus visual axis? Now we can see this geometric axis versus visual axis difference when we take topography. You will notice when you ask the patient to fixate down the axis of the instrument at the center of the Placido ring, in other words, we want to image along the line of sight, you'll notice that the rings appear to be pulled more toward the nasal side. And that gives you a topography with more blue on the nasal, less coverage of the visible iris on the temporal side. So we are seeing that temporally displaced fovea and how patients aren't being captured along their geometric axis. They're captured along the visual axis. Now, another issue that we face in multifocal contact lenses is that our pupils are displaced slightly nasally. You'll notice these two arrows are the same length, but one is going from pupil to border, the other is going from pupil and falling well short of the visible iris. So our pupil appears to be slightly nasal on this right eye. And in another study at Pacific University to look at left eyes and right eyes, it was determined that the decentration of the pupil appears to be nasal in both right and left eyes. It was also found that the decentration of the pupil is slightly superior in both right and left eyes. So in other words, our pupils are slightly in towards center, nasal and slightly up toward the superior meridian. And that's seen here where we look at the pupil decentration more toward the nasal side in the right eyes, more toward the superior hemisphere on the right eyes. Same thing with left eyes. Decentration more toward nasal in the left, superior also in the lefts. So our pupils appear to be decentered in and up. Now this might be an issue if our contact lenses are decentering slightly temporal on the right eyes, if our line of sight is more nasal and more superior. Our optic axis of lens may not line up with the visual axis or the patient's line of sight. Another anatomical feature that we're facing is what we call at Pacific University is the nasal notch, this transition or junction point between the cornea, limbus, and sclera, where on the nasal side there appears to be this dual angle or junction point in many of the eyes that we tested. So will that junction point decenter all of our contact lenses? So in another study at Pacific University, we looked at the principal multifocal lenses on the market at the time and where they were centering in relationship with the visual axis. Corneal topography was used to better understand that centration or decentration. As an example, we see the AccuView Oasis -3 with a 250 add, so a -3 distance, 2.5 diopters of add. In the center of the grid, where this little white cross is, that's the patient's visual axis. The pink is the approximate border of the pupil. Yellow is where we drew in where we thought the optic zone of the lens was, or where one of the zones of the lens is. And you can clearly see by the central distance, the near, the next zone of distance, the next zone of near, how the lens appears decentered temporally in relationship with the visual axis. Now, when we switch to the pure vision, is it any different? And you see visual axis here, pupil here, zones of the lens appearing slightly temporal and slightly high. So our visual axis and optic axis are not lining up. Here's the air optics. Visual axis here in the center. Then you look at your rings of the zones of the lens, and we see again this temporal decentration on this right eye. Biofinity distance, no different. Distance zone here, near zone here. And we see on the visual axis, these lenses appearing to ride more temporal of the visual axis or line of sight. The biofinity near, no different. Line of sight here, center of the optic axis, about a 0.5 millimeter different. So there's this differential between the line of sight and where our contact lenses are positioning. And that may be one of the challenges to why we see so few patients in multifocal contact lenses. Now, we looked at sagittal depth in our patients and the centration of these lenses based on sagittal depth. Are the lenses positioning perfectly centered to the visible iris? So let's take our first patient, and we notice for patient YC, the lens appears relatively centered. Now this would be good. However, consider that your pupil center and your line of sight are going to be coming through slightly nasal, slightly superior. So if our contact lenses are perfectly centered, that may not be the optimal position to line up the optic axis and the visual axis. Here's patient CR, and now we're noticing a slight amount of temporal decentration of our conventional standard soft lenses. Here's patient KD, much more temporal decentration. Patient ML, again, lots of temporal decentration. And all these lenses were fit to achieve the optimal centration, the optimal fit, movement, comfort. So if the base curve needed to be changed, the lens was altered. Patient SM, also decentering temporal. So from this study, we learned that the lenses tended in most eyes to want to position more temporally. And if, again, we know that the visual axis is nasal superior of center, then that could be a problem. Now, why is it that the lenses were decentering slightly temporal? So the group at Pacific did another study using the OCT to look at the shape of the eye well beyond the cornea. And what you notice is the temporal elevation has a greater drop in elevation than the nasal side. So one could say that the nasal height is higher than the temporal, or from the peak of the cornea, there is a lower drop in elevation on the nasal side, a higher drop in elevation on the temporal side. At the 20 millimeter chord, going farther out, you notice a much greater differential. Nasal side higher, temporal side lower, but by a much more significant amount. There was 173 microns at the 15 millimeter chord, so the difference between the height here and the height here on average between eyes was 173 microns different in elevation, but between the 20 millimeter chord from the nasal side to the temporal side, there was 838 microns of difference. Much bigger the farther we go out. In the left eyes, not quite as profound. The nasal side, the elevation was higher on the left eyes in 7 out of 18 eyes. The temporal side higher in elevation in 11 of 18 eyes. So effectively, the eyes were much more similar, the two hemispheres on the left eye were much more similar, which may be why the left eyes appeared in previous studies to be more centered or more slightly nasal. Now at the 20 millimeter chord, there exists this bigger drop in elevation, again similar to the right eyes. So at the 15 millimeter chord on the lefts, the nasal and temporal elevation of the eyes not that much different. In the right eyes, more different. At the 20 millimeter chord, they were significantly different between the nasal and temporal elevations in both rights and lefts. Now another study by Bruckner looked at pupil decentration and found that the pupils tended to be nasal and slightly superior, similar to the findings at Pacific University, and that was true for both rights and left eyes. So the pupil slightly nasal, slightly superior. Now we also have this issue with the aging eye called senile miosis, and that's as we age, our pupil size gets smaller and smaller, meaning we have less real estate to push the necessary light through the contact lens, through the smaller pupil, and back to the retina. So there is a significant number of challenges to soft multifocal fitting. The optics of the multifocals aren't as good as they could be, certainly not as good as in GPs. we need to compress all the powers that the patient needs into a very small area. We have the temporal decentration of soft lenses, especially in the right eyes. We have the nasal displacement of the pupil and visual axis on both rights and lefts. And then we have senile miosis, which gives us that smaller pupil and less light getting through to the retina. But are GPs any better for the presbyope? And we might look at how the GP optics are superior. We might look at how we can compress the powers into a small area, similar to soft lenses. So maybe a GP wouldn't be superior in terms of its ability to move the powers into a small area. GP lenses do tend to center more geometrically as opposed to more temporally. And this nasal displacement and slightly superior of the pupil and visual axis may also work against the GP lens. Similarly, the senile miosis is a challenge to GPs and soft alike. Now, how do we fit GP multifocal lenses? First, we have two basic types. Aspheric multifocals, meaning we have this change in power from center to periphery. We have also translating multifocals, where we have distance above, near below. The patient looks down to read, the lens moves up, the patient gets into the near zone on the bottom. With an aspheric multifocal, it attempts to provide simultaneous vision. In other words, we place the vast majority of powers that the patient requires within the pupil, and they hopefully will be able to find the focal distance that they need within that area of multifocality. Now, some of the aspheric multifocals require some translation. So again, the lens would hit the lower lid as the patient looks down, translate up, you would get into the power you need toward the pupil. That's the theory. In North America, we have two basic types of aspheric that dominate the market. Number one is your superior central or lid attached RGP lens that provides simultaneous vision with possibly some translation. Another approach is to fit a larger diameter lens centered to the cornea and provide simultaneous vision. So there isn't any translation, or should not be, to the centered simultaneous fit lens, the larger lens. Now let's look at the shape of the eye and how the cornea may govern the position of lenses. When we have a geometrically centered periphery where our GP lens will land, that should promote centration of the GP lens. If you see a displacement of the periphery of the cornea, that may cause decentration of your lens. So in other words, where the lens lands down, is that decentered in relationship with the patient's visual axis or pupil? So looking at the baseline topography can be beneficial. Which one of these eyes should have a well-centered lens thanks to the shape of that peripheral cornea? We might argue that this is the most symmetric. That green-yellow border appears to be symmetric or equally distant from the center of the cornea. This one here, we notice the hot contours, pulled more superior. This left eye, pulled more temporal. This right eye, pulled more inferior and temporal. And this left eye, pulled more temporal, a little bit inferior. So look at the corneal displacement to determine where your lenses may center. Now, the apical versus limbus to limbus cylinder may help as well. If you look at these two eyes, we have similar central corneal astigmatism, 1.6 diopters on the left image, 1.5 diopters of corneal cyl on the right image. So how are they different? Well, look at the shape of this astigmatism, very much confined to the center of the cornea. Whereas in this eye, we see this limbus to limbus shape where the hot meridian runs from one side of the eye to the other. So how are these eyes different? Well, in the apical astigmatism, we have a better shot at aligning the lens 360 degrees around. With limbus to limbus astigmatism, now we're generally only able to align on two opposing sides, whereas on the steepest meridian, we're going to have a much greater change in elevation, more drop in elevation, more vaulting of the lens at 12 and 6. So we may not be able to center the lens as well in the limbus to limbus cornea. Now, when we drop an aspherical GP multifocal on eye, the goal is that it's relatively centered to the pupil, maybe slightly lid attached, riding a little bit high like a normal lid attached single vision GP lens. Part of the thinking is that we have the distance zone in the center plus toward the outside. A lens that's relatively well centered should provide good distance vision. Then there's some intermediate there. If the pupil enlarges, we get into more of that intermediate plus power. For near vision, when we focus on objects much closer and that dilation of the pupil, now we're able to get into more of the plus toward the outside. The essential lenses that Precision and Cardinal distribute from Blanchard provide 3 series of adds, meaning different add powers based on a certain zone size. So if we were to take 1 millimeters distance from center, the series 1 would provide 3/4 of a diopter of add. The series 2 would provide 1 diopter of add. The series 3, 1.37. So that would be based on 1.5 millimeters from center or a 3 millimeter pupil. If we went to a 5 millimeter pupil or 2.5 millimeters from center, the series 1 provides a 2 3/4 add, the series 2 a 4 add, the series 3 a 4.5 add. So what you find is as you go from series 1 to series 2, you're increasing the add series 2 to series 3, again increasing the add even more. You're pushing more plus within a smaller area of the pupil. And that can be seen here, where the series 1 has this wide blue zone, this wide distance area going up to a 1.5 diopter add at a 4 millimeter pupil. Now, if we were to take a series 2 lens, we have a slightly smaller distance zone with more add being introduced at that 4 millimeter pupil. Now we go to a series 3, the highest add. We have the smallest distance zone with the greatest ramping up of the plus or greatest add toward the periphery. The way that essential series works is with a lens in primary gaze, the patient should have good distance vision by looking through the distance zone of the lens in the center. If it's slightly superior, then there is still some distance vision being provided. Now with the reading tasks, as the patient looks down to read, the lens should hit the lower lid and move up. Then the patient gets into more of the plus in the lens toward the inferior or the periphery of the contact lens. So a well-centered lens or slightly superior central should provide good distance vision for the patient. Then when the patient looks down to read, that lens should translate up. The patient should be looking through more of the intermediate or near portion of the lens. So it's slightly based on a translating principle. Now, if the lens is riding high and the fluorescein pattern is showing a flat fit, then you're going to steepen the lens up. So if the lens is touching the central cornea or has a thin fluorescein with a high position, we're going to steepen the lens to bring it down. If the lens is showing lots of central fluorescein riding slightly low, then we're going to flatten the fit. If there's lateral decentration, we're going to check whether we have an against the rule cornea or whether we have a flat fit. If the distance vision is poor, then obviously we're going to check the power. Have we under minus the patient? If the lens appears to be the right power, could it be due to centration? Is the lens riding too high, resulting in the patient picking up too much plus? So one might manually center the lens to see if better distance vision is possible. Now, if near vision is poor, again, we're going to check the total power of the lens. Have we under plussed the patient? Have we over minus or given the patient too much power for distance, in which case we could back off some of the distance to provide better near? Do we have the appropriate translation? Is the patient getting into that plus toward the periphery? Or do we simply need to modify the add, push more plus into the center of the lens? So the essential lenses come in 3 series, series 1, 2, and 3, and actually there's a 4th as well in a very extreme case, but the vast majority of fits are going to fall into series 1, series 2, or series 3. And there are numerous designs available for the presbyope, each one constructed slightly differently. The nice thing about the Essential series is they allow us to empirically order. We don't need a trial set, although you can get one. There's no risk to trying the lenses. If they're unsuccessful, we can return them for full credit, and we have 2 exchanges to try to get the fit right. Again, 100% credit if unsuccessful. Now, we mentioned that there's 2 philosophies of fit. We can fit a superior central lid attached lens that's an aspheric that's slightly translating, and that would be an essential lens. The precision technology dominated lens is an aspheric but centered for simultaneous vision. So what we're trying to achieve is the entire amount of multifocality distributed within the margins of the pupil. So what we want is a well-centered rigid lens. When you look at the power cross-section of a lens on the appropriate axis, you get a certain aberration reading or wavefront error. But what happens when those lenses decenter? When we have lenses that are slightly superior central, what does that do to the power cross-section? And the aberrations are increased significantly when we decenter our lenses. In fact, the radial astigmatism, the vertical coma, and the spherical aberration are increased when you have a multifocal lens decentering high. So this tells us that it's important that we should be shooting for centered multifocal lenses rather than superior central lid attached fits. So the Apex multifocal from Precision and Cardinal uses a large diameter lens designed to be more centered. If we have less movement from our large diameter lenses, we have improved comfort. So it's not just for centration, it's also to improve the patient response. Now you can imagine when you fit a patient with a larger lens, the larger the lens, the greater the sagittal depth. So when you land farther out on the cornea, you're going to have more depth, more stability. You have a better chance of a centered fit. Another component is when we use a spherical optic zone on a high eccentricity cornea, a normal prolate cornea with a high E value. This is the typical shape of the eye, high eccentricity, we have a lens that may land in an acute manner over a narrow surface area of bearing. So if you use a spherical optic zone on an aspheric surface, you get this acute point of bearing. However, if you use a high aspheric surface on a high aspheric cornea, you get this beautiful wide area of landing, which may improve comfort, may improve the bearing of the lens on the eye surface. Now, this larger diameter with the aspheric surface is an important feature of the Apex multifocal. So when you're dealing with normal visible iris diameters of 11.5 to 12 millimeters, you're going to choose a 10.5 diameter lens. When you have VIDs larger than 12 millimeters, then you're going to use an 11 millimeter lens. When your VID is 11.0 to 11.4, then you're going to go down to a 10.2. If you have a VID smaller than 11.0, then a 10 millimeter lens may be what you choose. So you're fitting much larger lenses than traditionally fit in single vision lens practice. Now, it's important to know what we're distributing within the pupil. And this study at Pacific University looked at if we built a patient a 2.25 ad, what amount of power would they actually be achieving or receiving? So we used corneal topography to appreciate what kind of powers are distributed within the pupil. And if we look at the topography in the center at 0 distance, that would be 0 ad coming through. If we go to 1 millimeter pupil, 1 millimeter diameter pupil, there would still be 0 ad. If we went to a 2 millimeter pupil, a very, very small pupil, even in an advanced presbyope, we're only getting about 0.1 diopters of ad. If we go to a 3 millimeter pupil, now we're seeing about 0.6 diopters of ad. So in other words, only about a half diopter of ad is kicking in at a 3 millimeter pupil. At a 4 millimeter pupil, we're getting 1.25 diopters roughly of ad power. At a 5 millimeter pupil, which isn't typical for a presbyope, we're getting the 2.25 ad. So if this were a normal young child that needed some kind of ad, we might be providing the 2.25 ad at a 5 millimeter pupil. But for the presbyope, at a 3 millimeter pupil with this lens, they would only be getting 0.6 diopters of ad, not much. So it's important to know the pupil size. What pupil do we need to distribute our powers within? If we're dealing with a 3 millimeter pupil, and this lens would only provide 0.6 diopters of magnification. The 4 millimeter pupil, we'd get 1.25. The 5 millimeter pupil, we'd get 2.25. But if we had a patient with a 4 millimeter pupil and a 2 ad, we would need to ensure that enough plus was introduced into that pupil. So what is the pupil size? Measure the pupil prior to the ordering of the lens. So what are some of the things we learned in optimizing these lenses for our presbyopes? Number one, centration is everything. A centered multifocal lens will provide the patient with the best chances of reduced aberration and good visual quality. We need to measure the pupil size. We need to know how big a pupil are we dealing with that the powers need to be distributed within. It doesn't help to create a 2 ad out here at 4 millimeters if the pupil size is only 3.15. Then, if we know the pupil size, we can appropriately distribute distance, intermediate, and near within that measured pupil. If we optimize centration, we reduce the aberrations from a decentered lens. We create the lowest aberrations when those lenses are on the visual axis or geometrically centered, if they're centered to our eye as best we can. Now, an aspheric multifocal can be added to the front surface of any of the standard precision or cardinal lenses. So on a single vision lens, if your patient is transitioning to a presbyopia, we can add that multifocality to their present parameters if they're well centered. If they're a back or a bitoric, that can be added to the lens. If they're a keratoconic, that can be added to the front of the lens, or a scleral. But the key being the centration of those lenses and the centration in relationship to the pupil. If the pupil's highly decentered in relationship to the position of the lens, we're going to be challenged in the fitting. Now, how do you order these lenses? It's very straightforward. Ks and Rx, as well as the add and the pupil size, are what we need. But if you have topography, the Rx, the add, and the pupil size, we're going to do a better job of that initial lens. How do you optimize the distance vision? Well, it's important that those lenses stay on center, as we said. So by ensuring that you're creating the best possible fit to align to the cornea centered, then we're going to have the best chances of success. If they're decentered, then you know we've got to look at the fluorescein pattern. Is it flat? Is it riding high? The combination of the two indicating we need to go steeper. Is the lens showing inferior decentration with lots of central pooling? Then we know we need to go flatter. Is the lens laterally decentering? If it's against the rule cornea, we may have to try to fit a toric in order to align it better. But if it's not an against the rule eye, are we too flat? Normally lateral decentration is a lens too flat. To optimize the near vision, we may have to push more plus into the pupil. So if the patient has good distance vision and good centration, but the add just isn't there, we may need to cram more plus into that smaller area, more plus into the pupil. Now, how do you optimize that near vision? Again, check the centration of the lens. Check the spherical, the distance power. Are we over minusing the patient, making it more challenging at near? Do we need to change the asphericity? Is the fit basically perfect and the distance vision is good? It's not over minused. So should we change the asphericity to add more plus into the pupil? Now, with the Apex multifocal, you have a comprehensive warranty. You can empirically order these lenses at no risk. Again, you have 2 exchanges to get the fit right with 100% credit if the fit is unsuccessful. So there's no risk to try the Apex multifocal lens. You have 2 approaches. The Blanchard style essential lenses that you can order from Precision or Cardinal. You also have a centered simultaneous fit lens, the Apex multifocal, which we believe is the future of multifocal lenses. The small diameter essential-like lenses come out of an era of fitting 9.2 and 9.5 lenses back in the 80s and early 90s. Fitting has evolved. Large diameter lenses have taught us that we can create better comfort for patients, better centration of the optics, better visual outcomes as well. Now you have 2 approaches, the simultaneous vision lens and the centered simultaneous lens. So slight translating superior centered lens or the very centered simultaneous vision lens. Now, if you want more information There's various videos on the YouTube channel that provide some understanding of how we might approach the presbyope. So go to YouTube, look up Precision Technology Services, and you'll see numerous videos on various topics that you can review to learn more about fitting the Apex multifocal lens as an example. Now, it's not just the myope, pardon me, it's not just the presbyope that we fit with multifocal lenses. We also fit our multifocals on our emerging myopes. And one of the issues that we see with the emerging myope is this great increase in myopia in the next generation of kids. That, in other words, there's greater frequency of myopia, and there's also a greater severity or higher rate of myopia happening. Now, why is that? And it's believed that the peripheral refractive error has something to do with it. In other words, when we correct a patient on the fovea, we land the peripheral light rays beyond the retina, creating hyperopic defocus. And this appears to be a signal for eye growth. When we do orthokeratology, we create most minus in the center at the fovea, but less minus toward the periphery, moving the light rays forward of the retina or on the retina rather than behind the retina. When you fit any patient with any type of contact lens, you might notice that in the center we have our highest dioptric power, most curvature. As we go away from center, we have less power. We have this drop in power as we move away from center. So if we put the patient into glasses or soft lenses, we're going to lose power as we go away from center. If we fit the patient with Ortho-K, we create this reversal. The most minus in the center, most plus toward the outside. We actually create an increase in power moving away from center. We create more plus as we go away from the apex of the eye. So in a normal cornea, a normal prolate aspheric eye, steepest in the center, flattest toward the periphery, it's the wrong eye shape for bending light and controlling myopia progression. However, in orthokeratology, when we change the shape of the eye, minus in the center, plus toward the periphery, moving the eye away from an aspheric closer to an oblate surface, now we have less progression in myopia. So this myopia control can be created in various contact lenses. We can do this in Ortho-K, but we can also do this in multifocal lenses, creating minus in the center like we do for Ortho-K, but plus toward the periphery like we do with Ortho-K. So reversing nature's shape on the anterior surface from steepest in the center, flattest toward the periphery, to flattest in the center, steepest toward the periphery. Same thing with the multifocal contact lenses. Flattest in the center, steepest toward the periphery. Now, if you take a multifocal soft lens and do topography over the naked cornea, over top of the soft lens on eye, the multifocal lens on eye, you see that differential. Minus in the center on the visual axis, plus toward the periphery, creating that minus center plus periphery. Less power on the fovea, more power in the periphery. And numerous studies have shown us that multifocal soft lenses fit as myopia control devices cut the myopia progression by approximately 50%. When we do orthokeratology, we see within the measured pupil, we get this big shift from the center to the periphery. There's a 2.6 diopter shift in power, or let's call it a 2.6 diopter add. So we could do the same thing with a multifocal rigid lens, the same way we do with soft multifocals, the same way we do with orthokeratology. If we create a lens minus in the center, plus toward the periphery, we can produce those changes in the bending of light toward the peripheral retina. So as an example, here we see a pupil of approximately 5 millimeters, and our most minus in the center, most plus toward the periphery. So this is a map over the anterior surface of a multifocal rigid lens. In fact, an apex multifocal from Precision and Cardinal. So when would you use myopia control GP lenses, myopia control multifocal GPs? Well, possibly when the RX is on the higher side, when orthokeratology is less successful, when you are outside of the parameters of a standard soft multifocal lens. What about if the astigmatism is higher than a multifocal lens can manage? Then you might use a RGP because it can manage any amount of astigmatism. If you were concerned about the compliance for the patient, if you were concerned about them wearing a lens in a closed eye environment, overnight wear, then you might consider GP lenses, the safest lens on the planet with the lowest microbial keratitis incidences. Now you can fit a multifocal rigid lens for your myopia control patients in virtually any format. The conventional small diameter GPs, the high aspheric GP lenses available from Precision and Cardinal. You can fit them on bi and back toric lenses. When you fit them, the same considerations that we have with our presbyopes. Aspheric optics are positioned over the pupil as well centered as we possibly can. So we'll alter the fit to achieve that desired centration. We're going to measure the pupil size and push as much add as we can within the pupil before the patient begins to lose quality of vision or before the visual acuity goes down. So generally we're going to use a 3 to 3.5 diopter of add for our kids as a myopia control device. We're going to over-refract our trial lenses to push the necessary minus to provide good distance vision, but also check that we're still providing quality near vision as well. So check both near and distance, and if we have inadequate distance vision, we may need to reduce the asphericity or reduce the add. If we have inadequate near vision, then we may need to increase the add. But generally, young kids have incredible accommodative powers, so we generally don't need to increase the add unless the patient isn't getting the myopia controlling benefit. Then we're going to up the add power. So ensure that within the pupil size, we're building that distribution of add required. Too small an add power, and that may not move those light rays forward of the retina in the periphery. So push as much add as you possibly can. So as an example, this might be a typical fit where we have our apex multifocal lens, base curve 780, large diameter 10.5, minus power with the appropriate E value and the add power at the pupil size. What add at the pupil will give this patient the myopia controlling powers that we need. So how do you order them? The same as we would for a presbyope. If you have K readings alone, then we'll take those along with the RX and the pupil size. Or if you have topography, then we're able to build a more accurate lens the first time more often. We're going to ensure that we can center these lenses to the best of our ability. So we have two things that we can use these multifocal lenses for, not just for the presbyope, but also for these kids as a myopia controlling device to ensure we're pushing enough plus into the peripheral retina, making sure we move the light rays forward of the retina, not behind. Again, how much plus do we push within the pupil size? That's one of those important components that we need. What is the pupil size? Make sure that we push the high add within that pupil that's necessary. So we're generally going to target a 3 to 3.5 diopter add for our kids in their multifocal GPs when we're shooting for myopia control. So the Apex Multifocal is one of those tools that you have available to you that we can use for both the adult presbyope and the young child.